We're at the part of the agenda where we're going to have some summary remarks, while probably an impossible task to fully recap everything that was shared today. We enlisted the best person that we could to make the best stab at it, and that's Dr. Eric Immel. If you don't know him as an associate professor of medicine and pediatrics at Indiana University School of Medicine, he completed his fellowship and is dual certified in both pediatric endocrinology and adult endocrinology. Dr. Immel conducts clinical and translational research in rare and common musculoskeletal diseases, including serving as co-investigator on multiple burosumab clinical trials. So please join me in welcoming Dr. Eric Immel.
All right, well, thank you. We started out today with Susan pointing out something that I don't know if this was the big thing she wanted to point out, but it was the first thing that my brain latched onto when she was talking, which was something that's also been in my mind a lot over the past few years, which is that there needs to be a greater recognition among both patients and doctors that XLH is not just a pediatric disease. And this was a theme that was reiterated throughout the day in a lot of different comments. And as a personal aside to that, this is something that's probably an artifact of our understanding of the disease, even going back 30 or 40 years ago, when the thing we could measure the best in terms of our outcomes were height. And so once kids were done growing, we knew that there might still be some benefit to being on treatment, but we knew there were definitely some harms to being on treatment with calcitriol and phosphate, as many of you have actually experienced some of those harms, including problems with nephrocalcinosis, some patients with chronic kidney disease, people who have had to have multiple parathyroid surgeries over time, and some of these other problems that are a consequence of what's been conventional therapy for the last 30 years has influenced doctors' decisions about when do we treat and when do we not treat. But I think the adverse side effect of that has been communicating a message that, oh, you're fine now. Therefore, any problems that you're having can't possibly be due to XLH, and we have to go think of something else. And I've seen a lot of people get a lot of unnecessary evaluation for things that aren't really the problem, and that maybe what needs to be done is addressing the XLH. Now, some patients I noted describe doing relatively well for a while after stopping therapy when they're done growing. But I also noticed that most people who mentioned that didn't describe having no symptoms. They described having mild symptoms and somewhat manageable symptoms for a period of time and then gradually getting worse. And I think that's important to note, that even doing relatively well off therapy may not be being symptom-free, and that may have some impact as we think about how best to manage XLH. But then, of course, another big problem is access to clinical providers, access to people, to doctors who have either some experience with XLH, of which there are a few of us, even more so, people who are willing to take some extra time. And that's a challenge because a lot of doctors have a lot of time pressures and have difficulty stepping out of their comfort zone and doing that because of those time pressures. But also, I think we don't necessarily need to expect every doctor to be an expert in every rare disease, because that would be virtually impossible. But one single high-yield thing that Dr. Jandeber and I were talking about that would probably have gotten many people to getting more treatment sooner, especially in the case of TIO patients, is if phosphorus were just routinely measured, and it's not. And so many of you who may have seen delays in diagnosis and treatment, that may be part of it. As we went on throughout the day, we talked a lot about how once you start to have symptoms again, or maybe your symptoms didn't go away completely when you're a young adult, but once you start to have symptoms again, there's a gradual increase in disease burden over time that really just seems to increase with ongoing years. And that impacts a lot of things. It impacts things we would like to be doing that would be fun, or meaningful, or sometimes things that have to do with being able to work or take care of your house or your family. And there was a lot of concern about what that impact would be as people develop more problems with their XLH. Mobility and pain control have certainly been big issues. And I think that this really is a big unmet medical need, especially the enthesopathy. A lot of the symptoms that you guys are describing as the most debilitating things in your life relate to this calcification that's places it shouldn't be, leading to the spinal stenosis surgery and leading to joint immobility and stiffness and pain in many situations. And I think these are all places that we need more research, and places for which we don't have great information. We know for sure that calcitriol phosphate at this point in time do not benefit the enthesopathy. We actually have no information to tell us whether burosumab is going to benefit the enthesopathy or not. There are some theoretical reasons that it might be of interest, but we have no evidence from any of our research trials, and that's going to take a long time to actually develop because it's something that progresses slowly. But I also saw some hope. There were a lot of people that are very hopeful in terms of their experience with therapy with calcitriol phosphate when it's working well for them, with burosumab when people have had the opportunity to do that, and also a good awareness of what additional things we need to address, because I think that as we continue to learn more about XLH, we're going to need to try to address some of these other things that are sort of ancillary to the primary bone problem. Thank you. That's my impression of the overall summary for the day, and I'm at the end of my notes, so.